The content of this podcast is based on medical fact and evidence-based practice from credible authoritative sources, but is not a substitute for your institution's policies, procedures, common sense, or good judgment. The views and opinions are those of Eric Bauer and Flight Bridge Ed in their entirety. This is the Flight Bridge Ed podcast, critical care and emergency medicine education for nurses and paramedics. Here's your host, Eric Bauer.
Hey everybody, Eric back with you. In today's podcast, we're going to dive into all things RSV. We're going to talk about a great case study, a very difficult case study that starts out seemingly very stable, but we're going to look at the escalation of care, how the baby ends up moving through the presentation, how it was dealt with. We're going to look at all things related to evidence, what we may do in the field. Are there anything out there that we could do different? What does the data show? Had a great conversation with Peter Antevi on this subject. He was able to shed some light on maybe some misconceptions out there, what he sees in the pediatric hospitals, what he does personally. How does that relate to maybe what we've seen over the years, and talk about some misconceptions. We'll talk about some new approaches. Before we jump into that, though, I wanted to really dive into the data and identify, have we really seen an increase in RSV? Is it as much as it's being reported? So I was able to pull the data from the CDC and look at 3 different year comparisons. So I started off and I looked at from 2020 to 2021, and I wanted to identify what the incidence of RSV was, and the way they extrapolate that, it's per 100,000 individuals. And so from 2020 to 2021, that was 12.4 individuals. So 12.4 people out of 100,000 got RSV or acquired RSV. We know that that is when COVID started in that time period. If you look at then 21 to 22, that same period of time, it more than doubled. So it increased by 128%. And then if you then look at and you compare that original set of data from 20 to 21, so again, that's our starting point. And we're using that starting point because I wanted to see if COVID played a role in the increase. You look at 22 to 23, there's a 275% increase in overall incidence. So we go from 12.4 individuals per 100,000 to 46.6. So that definitely is a huge increase. I wanted to then look at what was the higher incidence, male or female, and it was male. And was there an age range that saw a higher infection rate? And that was 0 to 6 months. So I think based on that, we can definitely say that there's something has changed. Is it maybe the isolation that we saw? Was it people wearing masks, not being exposed to all these different things, and then we all of a sudden we're out and about, and that's probably one of the big reasons. So this case, as I said, really does highlight a lot of great teaching points. Some of this stuff will be reviewed. Some of it might not be, might be new. So we're going to follow the path of a 4-month-old male that's brought to the ED by his mom. She states that over the last 4 days, he's progressively started what she thought having a cold, had a little bit of a running nose, didn't have a cough, but she's noticed that he has become more tachypnic over the past 4 days. Last night, it culminated to a progressive fever that was about 101.1. She did say that this morning that when she did change him, he did not have a wet diaper. And as she recalls, his eating and drinking habits over the past couple days has diminished significantly. She did say that he has had no vomiting, no diarrhea. He's had no cough, nothing productive whatsoever. But she does say that he does have a rattle when he breathes. He kind of sounds funny. and his chest looks funny. On assessment, he does appear to have some mild retractions. She did say that he does go to daycare and that there have been other kids at the daycare that have been sick as well. The initial set of vital signs, they note his blood pressure is 88/46. He has a heart rate of 130 and a saturation of 91%. So they do start him on a nasal cannula at 2 liters per minute. They do establish an IV in his left AC, and they start a 20 mil per kilo bolus of normal saline. Based on their protocol, they do start an albuterol nebulizer. Based on lung sound assessment, they do identify wheezing, and they do send off for a full set of labs, a chem panel and a viral panel. After the initial bolus, they do note that the baby has not had any changes in vitals, so they do initiate a second bolus of 20 mils per kilo. The oxygen saturation does increase to 93%, but his wheezing is noted to be unchanged, and his work of breathing, however, has improved a little bit. So they continue him on a second nebulizer treatment at this point. And we're going to stop at that point. We're going to really break down the disease process. So if we look at RSV and we talk about all aspects, we know that RSV in most cases, it's always a virus, right? And it manifests and progresses to the bronchiolitis stage. We know that you have a much higher incidence in the winter months. And when we look at the overall incidence of bronchiolitis, RSV, you can always pretty much say that they go together. And so that just means that that virus has then infected the bronchioles. And we know those bronchioles are those smallest little airways in our lungs, and the infection basically makes it to where those little bronchioles swell. They become inflamed. We start seeing mucus production and collection in those airways. We start having mucus plugging. We know that can cause small little opacities or patches of consolidation that causes collapse in those areas or atelectasis. And you have a very, very poor airflow in and out of the lung, just again based on how progressive that disease is. Most cases of bronchiolitis are caused, as I said, by RSV, and RSV is really the most common virus that infects just about every child under 2 years old. As I said, the data really showed and supported that the highest incidence of RSV is 0 to 6 months. When we look at really the outbreaks of RSV, right, every winter you're going to have a big increase. We definitely have seen, based on the data that I presented, that the increase has been staggering. And you can have individuals that can be reinfected. Just because you get it once doesn't mean that you are not going to get it again. And just because it's more of a pediatric-related virus, that doesn't mean adults can't get RSV. Adults definitely can get RSV. Previous infections, though, do not appear to last or last longer than the initial one. And those previous infections, as I said, they do not cause or build an immunity for secondary or other infections over the years. We also know that bronchiolitis is not just isolated to RSV, and it can be caused by other viruses like the flu or the cold. And so don't always just assume that just because the patient has bronchiolitis that it's RSV. Obviously much more common, but that is not the case. As I said, really looking at it from the incidence, you're going to have these smaller little guys, infants, up to 6 months old as the most common. But that doesn't mean we see all of these patients as far as in the ER or in a transfer setting. I think where you're going to see more of these is, not all parents are going to just jump up and take their child to the doctor. Definitely have parents that may not have access to health care, that may have delayed care. You might see more rural or remote areas having a higher incidence of kids that are maybe more sick. And that could just be due to demographics. It could be due to, a lot of different, reasons. But it usually is these kids that are more sick is probably going to be more related to a delay in care, or the progression has not been identified, and proper treatment or care has not happened. One of the things that we have to understand is, even though that our number one age group is that 0 to 6 months, those are the kids that are probably going to have more of a severe presentation. And so just like a cold, they're going to have the runny nose, they could have sneezing, they could have coughing. Once we progress to where we have the wheezing and we have the associated fever, I think that's where you have to start really watching, making sure that we have good intake and urine output. When you start seeing these kids become fussy, right, they start having a decreased appetite, they're not wanting to eat, really not interested in anything that's normal, they don't want to play, they start having breathing pattern changes. I think that's where hopefully a lot of times parents kind of clue in that maybe this is a little bit more than our standard cold. And then obviously we can see these kids progress to a more severe illness where we could start seeing a pneumonia. If we go back to our case, they did decide to do a chest x-ray. Chest x-ray, there was some perihilar opacities that were really streaky. There was some hyper expansion noted, but there wasn't any focal consolidation in any specific area. They did make the decision, just based on their capabilities, that they did want to transfer this little guy to a pediatric center, so they do call a transport team, and they're given a 30-minute ETA. While waiting for the acceptance and bed assignment, the infant does develop an increased requirement for oxygen. Saturations drop back down into the 90-91%. They do transition the baby to a non-rebreather mask, and they set an FiO2 to 35%. So on a reassessment, right, work of breathing is moderate. There is, poor aeration, wheezing throughout, and they note that the wheezing really has not improved despite the albuterol treatment. So they make the decision to progress to racemic epi, nebulized, and that actually seems to help. About the same time, the respiratory panel does come back positive for RSV, so we do have a confirmation. We do have the RSV with bronchiolitis. So let's look at this from really the plan of care. If you were to have this patient, what are some things that you would want to either confirm when you come into transfer? If you're a 911 unit and you're arriving on scene to find this baby at the house, what are you going to focus on? All right, number one, obviously you're going to assess the airway. You're going to identify, is there any lethargy? Does the baby want you around, want you to touch? Does he or she want to be held by mom, or is it really not an issue, right? That should always be one of those areas that give you a high index of suspicion that this kid is probably, sicker than maybe you would want. And so obviously you want to start oxygen support. I think starting with a nasal cannula is more than appropriate. And we know that even 4 to 6 liters a minute via nasal cannula on these infants actually provides a significant amount of PEEP. So it does go a long way. We definitely don't want to give anything by mouth at this point. So I would not feed the child, no bottles, no breastfeeding, if you can help it. And we need to get an IV established. And I think that's the big thing, is really maybe you have a fear or maybe a reluctance of starting an IV on an infant. I think for some it's not a big deal. For others, I've seen some hesitation. I think the key is to use your skill set, use all the IVs you've established over the years, and go with an IV location that you feel you're going to be successful at. I have found that going at AC, even if maybe I'm using more of an anatomy approach and I don't see the vessel, usually you're successful. It's better to start an IV and not need it. And obviously, we could escalate to an IO if the baby was sick enough, but I definitely would wait to escalate to that level. We want to provide cardiac monitoring. We want to continue to watch not only our rate, but what's the mechanics of breathing? Do you see any retractions? Do you see any belly movement? And so don't be afraid to expose the chest. Evaluate if there's any fever. If you have anything with you to treat, antipyretics, give some Tylenol. And as I said, this is highly contagious. So do whatever you can to maintain isolation. A lot of times that's going to be a little bit more difficult on a scene situation or a transfer situation, but that is one key area in the hospital that they really focus on is continuous isolation. If we go back to our case, right, approximately 30 minutes later, they do note that the infant experiences a big increase in the respiratory rate. Rate is now calculated at 74 breaths per minute. He is now lethargic. SpO2 has dropped to 88%. Pulse rate is up to 182. They note that the fever is still climbing. Current rectal temp is 102.9. They have confirmed that Tylenol has been given. And this has been progressive over an hour. So, again, you got to reevaluate, make sure that Tylenol dose was appropriate. Identify, can you redose the child at this point? Obviously, 2 doses of Tylenol within an hour is probably not advisable. Saturation has fallen to, that 88%. Why has that happened? Supplemental oxygen was established at 35% FiO2 via non-rebreather. And so you have to start evaluating, why would the baby decline like that? What are some key areas that we see? And if we go back to the overview of the disease process, remember some of the big aspects to the pathophysiology. One of the big areas is the mucus production, right? That bronchiolitis and that mucus production really causes havoc. And if you start having mucus plugging and start having, these consolidated areas where you have atelectasis and collapse in or around small areas of the lung, obviously that's a pretty significant VQ mismatch, and you're going to have some decline. And the baby or you or I, if we're in that same situation, our body's only way to try to improve that is by increasing minute ventilation. So a respiratory rate of 74 per minute is not going to be something that can be sustained. Definitely much more sustainable for an infant than you or I, but we definitely have to think about, why is this happening? And I would immediately evaluate, does the baby need to be suctioned? Is it a positioning issue? And so just those little things. How is the baby positioned? Remember to pad under the torso. Make sure that the head is in a position to where you have an open airway. Remember, the head is much larger in comparison to their body, and so very easy to occlude the airway. And it could be simply just opening the airway, making sure head of bed is elevated to a safe point, and making sure that we don't have any mucus plugging that you can see. If we continue and evaluate that, what about nebulized albuterol? We've seen them give 2 doses of albuterol, and I think the thing that I see this when I teach, is just the automatic, hey, let's give albuterol. And I think there is a lot of data out there that shows, and it has for a long time, that kids with RSV bronchiolitis, they do not respond to albuterol. I think one paper that I read a few years ago said 1 in 5 patients respond favorably to albuterol nebs. Definitely think there's a lot of great literature to support racemic epi. I know Peter Antevi, we talked about that exact thing. Very, very quick for him and his crews to escalate to racemic epi in these kids. But one of the things I do want to point out, and something that is more intra-hospital that I definitely can see a need to progress in the pre-hospital setting, is there's a lot of good, favorable literature on hypertonic saline that is nebulized. And so instead of, we often have taught nebulized normal saline, just our 0.9%, but in the hospital they go to the point of 3 to 5% hypertonic in these kids, and I think they've seen a lot of good results with that. Now, how does that translate to our area of expertise? Right, we're in the field, and I think it's unrealistic, and this is one of the conversations I had with him, it's unrealistic probably to expect agencies to carry 5%, but I know that there's been a huge increase in agencies, whether they're ground agencies or HIMSS agencies, that carry 3% hypertonic for our TBI patients. So we definitely have that readily available, and so I definitely think that there's a use and a need for that hypertonic 3% in this case. And so that is something we should start thinking of. It should probably be the second thing you think of, or maybe start there. Instead of the albuterol, you go to that hypertonic 3% and nebulize that if that's something that you have available. Now, obviously, you need to talk about this with medical direction. If this is not in your guidelines, definitely don't hesitate to reach out. I can forward you these papers. I definitely know that Peter would be happy to talk to these different agencies on this. And he did say that, he's not seeing this in his area, right? He's not having his crews give 3% in RSV kids, but really it's more of a time factor. Their transport times are very, very small, and there's just not enough time. So, right, there's lots of different reasons why we may or may not carry something. I definitely think for areas that have long transport times, HIMSS agencies that do longer flights, or pediatric-specific teams, there's definitely an argument to start carrying or utilizing 3% as a nebulized option. So how does it work? Well, remember, 3% is going to be hyperosmolar, and it basically is going to absorb that water. It pulls that water from the submucosa, and that reduces any edema and improves mucociliary function overall. And so if we have overall improvement, a reduction in edema, and that reduction of water, a big reason why a lot of these kids start declining is, as I said, just that mucus production and the need to have suctioning. Well, what else can we do with a child like this? All right, we've talked about, we've got an IV established, we've already assessed the airway, we know that the patient has declined. We're a lot worse off now than we were when the baby came in. Fever has not improved. That's something that's very definitive. We can treat that. We have to watch that, but we have to think about that oxygenation side. What do we want to do? I think the key is, and I think one of the things that Peter Antevi said that really hit me was when you start talking about the advantages of albuterol and the outcomes and the advantages or disadvantages or the need for, as we're going to discuss here in a few minutes, corticosteroids. The greatest benefit is eliminating or reducing the incidence of intubation. That is the biggest thing. So what can we do that's going to reduce the incidence or need for intubation? And I think the big thing is non-evasive ventilation. Whether you have BiPAP for this subset of patients, do you have the capabilities, or do you have high-flow nasal cannula technology that you can deploy? And I think that is the new big thing. It's the biggest thing we can do. It's non-evasive, and it really does impact and reduce the need for intubation. High-flow nasal cannula technology really is about two things. It's about increasing the overall flow, and by increasing the flow, we also are able to lower our FiO2 requirements. That, in turn, will help reduce the incidence or need for intubation. That translates to a reduced hospital stay. It improves worker breathing, and it's much more comfortable for the patient. So lots of different guidelines and protocols out there. One paper I found had some recommendations as far as, age and weight and what our flow is. And an example for any infant that is less than a month old, they recommend high flow nasal cannula at 5 to 8 liters a minute, and that's really going to be less than 4 kilos. If we talk about a patient that falls in the age group that we're actually treating now, 1 month to 1 year, the flow range is right around 8 to 20 liters a minute, and that's 4 to 10 kilos. And then anything over a year old, it's 12 to 25 liters a minute. But again, the key is recognition and understanding that maybe the things that we have done over the years, the albuterols, the Atrovents, the things like that, those work for a certain type of patient, but that doesn't mean that that is the best thing for these patients. I think if you have the high-flow nasal cannula technology, there's a few key areas you have to make sure. Number one of the key areas is the nasal cannula device that you're using. You should never occlude greater than 50% of the nair. So make sure it's appropriately sized, and it always needs to have, a warming humidification element to it. We never want to give it outside of those two areas. When we look at this case again, one of the things that they started discussing was the need for corticosteroids. We commonly get this in a lot of the different respiratory diseases, asthma, anaphylaxis, those things like that, COPD patients. But is there truly literature that supports corticosteroid use in RSV and bronchiolitis? And the answer is no, right? It's the review really is conflicting, and it really is maybe beneficial, maybe, in somebody, a pediatric patient that has known reactive airway disease. They've got a history of asthma. They've got a history of some other reactive airway disease. It could be beneficial. But these patients, when they looked at them, even if they had a mild reactive airway disease history, they didn't do any better, and they didn't have any shorter hospital stays. So really, the literature shows that there was no improvement. It did not benefit the patient in this type of disease process. So I think that's the key. What does the data show? I think that the data shows that that is not a need. And talking to Peter, he confirmed that and said that that is not something that they routinely do. So let's just recap the standard presentation. Remember, the majority of these kids are going to have a runny nose, are going to have a cough in some cases. Again, based on the progression of the disease, they might come in with no cough. Sometimes they're going to have a low-grade fever. It could be, again, higher based on how long care has been delayed. Tachypnea, maybe some retractions, wheezing as it progresses. And the key thing for us is to evaluate hydration. What's their normal urine output? How many diapers do they normally go through? What are they seeing now? Positioning. I can't emphasize the importance of making sure you have positioning dialed in, making sure head is neutral, making sure you're patted under the torso, head elevated. Simple airway maneuvers like that make a huge difference. Remember, supplemental oxygen for any child or pediatric that has a SAT less than 90, definitely need to treat that. But that doesn't mean we're going to automatically go with 100%. We're going to give what we need. Nebulized normal saline. If you don't have 3%, then use your standard 0.9%. If you have 3% and that's within your guideline, definitely go 3%. And we know that there's definitely benefit. Albuterol. As I said, it may or may not help. 1 in 4, 1 in 5 kids might see benefit. I definitely would use that as a last resort. Again, I would follow your guidelines, but these are things to discuss with your medical director. Fluid resuscitation. make sure you are evaluating volume status. Remember, we have our surrogates that we're going to target. We're going to target what is our normal systolic. Where does this child fall? Well, we know this child fell within the normal range. But don't stop after just 3 boluses. Remember, we use 20 cc's per kilo. We do 3 boluses, and that's really what PALS and NRP focuses on. But just because it says 3 boluses doesn't mean we stop. We have to continue to give boluses until we see a positive response. Isolation. Remember how contagious this is. And isolation is going to be probably more of a factor in the hospital. What about suctioning? Really, there's no evidence to support routine deep suctioning, but just standard suctioning is huge. And I think that is the key. If you look back at this kid and the sudden decline, the respiratory rate increase, lethargy, SpO2, I would focus in on, again, making sure the airway is open, make sure my positioning is optimized. I would make sure that I'm good and suctioned. And then really the aspects of what we might perceive, the corticosteroids or the bronchodilators, remember there's no evidence to support that. When looking at the outcome of this patient, the patient actually did do well. They did progress eventually to BiPAP. They did not have high-flow nasal cannula capabilities, so they did go BiPAP. Patient did respond well to BiPAP. Their settings, they did an IPAP of 10, an EPAP of 5, and an FiO2 of 40%, and there was improvement. Again, I can't emphasize there was a big focus on suctioning, on positioning, and really taking all of those things into consideration, implementing those. There was a positive change with this child. I think the key is for any pediatric patient that we transfer or transport or arrive on scene, right? The stress level a lot of times is magnified. A lot of times you have family that is a little bit more animated, we'll say. They're upset. Their stress level is higher. And it's very, very easy, as we all know, to get sucked down that rabbit hole. And I think the key is you control the scene. I think there's a lot of data. I know Peter Antevi and the Antevi company in general really has focused on resuscitation in the house or by the bedside, by the poolside, not grabbing and running to the ambulance, right? Just the delay that you have between the point you pick the patient up at or find the patient to getting into the ambulance, that delay is massive. And so, again, we have to control the scene. We have to treat the child. And I think there's a lot of good supporting data out there, both anecdotal and, proven data that shows that, doing more on scene in these sicker kids all the way to cardiac arrest patients is the best option. Use your weight-based guides. Whatever you use your weight-based guides. Don't memorize these medications. Remember that kids, they arrest for 2 reasons, respiratory and volume, right? Those 2 things. It's not always escalating to the most advanced procedure like intubation. The greatest benefit that we can give these kids is to keep them off the vent. In most cases, these kids are going to do really, really well with standard airway management from a BLS escalating to high-flow nasal cannula technology. And really, when you look at it, less than 3% of these kids are admitted into the PICU. So remember, lots of stuff that we unwrapped. I will attach in the show notes these different papers and studies that kind of talk about and highlight the benefits of corticosteroids, albuterol, hypertonic saline. Until next time, guys, if you have any questions, please email me, eric.bauer@flightbridge.com, and I will talk to you soon.
This has been a production of the Flight Bridge Ed Podcast, leading the way in pre-hospital critical care and emergency medicine education.